Okay, I'm going to try to explain the basics of 4 different healthcare systems: Japan, Germany, France, and the UK. And I'm going to do this using color-coded markers and the different players that we need to be watching out for and thinking about if we're thinking about healthcare systems. So I have the government up here, and we have Prime Minister, Government Committee. We've got doctors over here. We've got people over here. And of course, when the people interact with the doctors, they're patients, but since they're also going to be buying health insurance, they're not always patients. We've got employers here, which are part of the picture in some of these systems, but not in others. And then we've got insurers down here. Now, there's going to be 2 sort of lists of prices and quantity limits and such that matter. One is going to be reimbursement rates, which is essentially the prices that are relevant between the doctors and the insurers. And then the other price list that matters is the out-of-pocket costs to the patients. So in some countries, this is 0. In other countries, it's a percentage of these costs. In other countries, it might be a specific rate. And with a lot of cases, different insurers are going to have different setups for this document. So that's where we're starting from. Oh, and one more thing. Since this document matters a lot, we need a clear picture in our heads of what this is. So this document would say a 1-hour consultation with a general practitioner doctor will reimburse the doctor $90, meaning the insurer has to pay the doctor $90. Knee surgery will reimburse at $5,000, so once again, it's between the insurer and the doctor. Earwax removal, they're going to have a huge long list of all of the different possible services and the reimbursement rate. Now, some but not all of these are going to have also limits on quantity, like instructions for when it is or is not appropriate to provide these services. And economists, of course, care a lot about price and quantity, and in healthcare systems, this is actually a big thing. Do you pay more attention to limiting the price, or do you pay more attention to limiting the quantity in your system? And what will be the different effects of that? Let me start with the Japanese system, which is going to be in purple, and give you the basics of how it works. The key with Japan is that they're going to have a bunch of different insurers, and employers are going to be relevant in the Japanese system, but they're going to have a single document that is a government-based document to come up with these prices. Let's start here with the Prime Minister. So in Japan, the Prime Minister is going to set the budget for the total healthcare system. It's going to be a fixed budget. Now, with all of these countries, there could be a little bit of squishiness with the fixed budget, but at least the fixed budget is going to be the target total amount of spending. So it's going to limit how these rates are negotiated, where you have to think about what are the quantities from last year, and given the new prices, what would be the expected total cost of the system. But once the Prime Minister sets the budget, which might be expressed as a % increase from the previous year, or else no % increase, 0% increase, it could be expressed in different ways. It's not necessarily a dollar amount, but it will translate into a dollar amount. Then the decision-making turns over to a government-based committee. And that government-based committee is what's going to generate this document, which has the reimbursement rates. And in Japan, that's also going to include details that will limit quantity. And these are details about what different hospitals can do, how much they can do, who they can treat in various circumstances. So there will be a lot of specific details that sort of get at quantity. Big document. Now, of course, the doctors in all of these circumstances care a lot about this document because this is going to determine their income. So just like with other countries, the doctors are going to come together and the doctors are going to be lobbying this committee in Japan in order to try to drive up these prices. Now, you may notice that because the budget is set in Japan, there's a zero-sum game with these doctors. So some doctors are specialists, and the knee surgeon is going to really lobby hard to get this knee surgery up. Some doctors are general practitioners, and they care a lot about that 1-hour consultation. So there are going to be different doctor groups that are sort of competing with each other, and they'll have different unions. Now, I will represent that as there's sort of sub-unions here in Japan, where here's the general practitioners, here's the specialists, and they're going to be competing when they lobby this group. Now let's think about the people's experience and the employers and the insurers. So in Japan, there's actually no choice among the people about which insurer you have. You're going to get your insurer either through your employer or else through your community, which is essentially the government. It's just the government of your local setup. So there's no choice, but it comes through your employer. If you work for employer 2, then you get the insurance the employer 2 has to offer their employees. It's required for employers to offer this insurance. It's required for everyone to have insurance, or else you will be charged a fee. And I forgot to add a government-based insurer. So let me do that over here. I'm going to have the government-based insurance, which many of these countries will have. In fact, all of them will have for people who are uninsured. So I'll put that over here. So here we have our unemployed person, and this person is going to get their insurance through the government plan, which is community-based, but I won't include that here. And that plan, of course, comes directly from the government. All right, the next setup is the relationship between the employers and the insurers. And of course, the employers in this case do have choice. So whoever works for the HR part of your firm is going to do research about which of these insurers is better, which will better serve the needs of the types of people who work at that company. And so choice enters the picture in terms of employers who do a lot of research to figure out which one is best for the people that they are choosing for. And of course, in any healthcare system, when you have choice, that is one mechanism of accountability. Certainly not the only mechanism, but here there's no choice for people, but there is choice for employers. Now, of course, these insurers are going to have the opposite interests of the doctors, right? The doctors want these prices to be higher. The insurers want these prices to be lower because they're trying to attract employers who want low prices on the insurance. So the insurers are going to come together in Japan and they're going to lobby the government committee. These are the two parties in conflict to create this document. They're both lobbying the government committee, and there's going to be lots of publicity, lots of newspaper articles written about these negotiations, because that publicity is part of holding this group accountable to the interests of the general public when they come up with this document. That's the Japanese system. I think I might want to erase some of these purple lines to do the next one, or else this diagram is going to get really messy, so let me do that. Okay, so the way the German system works, the government is not going to directly come up with this document. This document is going to be negotiated between the insurers and the doctors. However, there is still going to be a global budget. So when they negotiate these, we still have a bit of that zero-sum game where the total expected cost of care can't go over a certain amount. So if you raise the price of knee surgery, you're going to need to lower the price of something else so that the budget plays out at the end of the day. And of course, just like in Japan, the doctors are going to come together and form different doctor groups that are going to try to negotiate harder in this negotiation process. And of course, there will be, once again, a tension between general practitioners and specialists. And the insurers are going to come together and try to pool their power so that they have more bargaining power against the doctors. So the setup for all of these, where there's a negotiation or whether it's a government committee, is going to involve a lot of either lobbying, if we're talking about a government committee, or else just coming together to bargain hard. Oh, one thing I forgot to mention with the Japan system is that this out-of-pocket rates to the patient is actually going to be part of this document that's negotiated by the government committee. So that's the Japanese system. Now back to the German system. So with the German system, now they're going to say that the system involves employers, but I don't actually think that's the best way of thinking about it, because within the German system, people will have a fixed percentage of their income that they have to pay into a government pool. So the government pool, of course, is just a pool of money that's collected through the citizens. And it's collected through the employers. So the employers take the 15% of their income, or whatever it happens to be, and they give it to the government. But that's not really a meaningful role. Like, the government could just let this be an income tax. There's lots of different ways that the government could collect what is essentially a tax on people. And the fact that they happen to collect it through the payroll is not going to have a huge impact on people or on the system or anything like that, other than maybe a little bit of shift in the tax burden because that's the way they collect the 15%. But I actually think it's a much better way of thinking about it to think about, okay, people pay 15%, and yeah, they pay whatever percent it is to the government, essentially directly, but it happens to be through the employers, that gives this pool of money that is then used to give people a voucher, or what I like to think of as a voucher, because I like visualizing things. So this is like a voucher that says you can use this to buy insurance from any insurer you want. And of course, that voucher is going to be risk adjusted so that sicker people have a higher dollar amount that will go to the insurer that they choose. So government gives people the voucher. The people then take the voucher to the insurer of their choice. So in the Germany system, we actually do have choice of insurers where the people are choosing, not the employers. And this unemployed person also gets a voucher. They pay 15% of their income, which is zero, into the system. They still get their voucher. They still have choice over what insurer they're going to use. So to summarize, employers don't have a super important role other than taking money from the people and handing it into the fund for insurance. But there is a big role between doctors and insurers in coming up with this document. All right, let me erase this and we will look at the French system. Okay, in France, we're going to have the government set the budget once again. This is a pattern in a lot of these countries where they're keeping costs way more contained than the US. Just like in Germany, we're going to have negotiation between the doctors and the insurers. In France, this negotiation is rigorous, having to do with reimbursement rates or prices, but they don't negotiate quantities like in some of the other systems. In France, there's going to be no choice of insurance for the people. The people are essentially going to get insurance based on their employer. Now, in France, the employers don't have a choice of which insurer to go with. Essentially, they go with the insurer that is most closely aligned with what they do. So you might think we have a teacher's insurance, and if you're a school system, then you have to then you're pooled with the other teachers in the country. If you are a janitor and this insurance is for janitors and probably a lot of other service workers in that sense, then you're going to go with that pool. So the employers are not going to be choosing anything. And these insurance pools are based on profession. Now, this unemployed person, of course, doesn't fall into the category of any of these professions. So the unemployed person is going to get the insurance that's the government-based insurance, and that will cover them. And of course, like in other systems, these insurers come together and negotiate. Oh, now one thing I should mention is that in a lot of these cases, the government can actually generate information that might be helpful for coming up with this document. So the government can do research on things like, on average, how much does it cost to do knee surgery? On average, how much are the supplies for an earwax removal? And that information that the government researches essentially ends up being really important in this negotiation process. So even when the negotiation is happening without the government's direct involvement, the government is still feeding the negotiation process information. And in all of these cases where the government is not involved in coming up with this document, the government still can set regulations if they want. Okay, let's do the UK. Okay, so the UK is socialized medicine, meaning the hospitals, the doctors, the providers are all sort of one with the government. So I'm actually going to do a big circle around all of this stuff. And that's all in-house. So because this is all in-house, the negotiation of this document is not this huge battle between the different players. Now, what does this mean in practice? So in practice in the UK, employers don't really matter. They're not a player in the system. People are guaranteed healthcare, and they, of course, this is negotiated. The out-of-pocket rates is determined by the government, and the out-of-pocket rates, of course, are zero or else low for all services. They just have to manage their budget within a certain target. Now, the UK has something called NICE, which is a government committee. Now, it's not the only government committee, but it's one of the more important government committees. And I forget what that acronym stands for, but it basically says what things are covered. And this is, of course, focused on quantity. It's when does someone get to have surgery and when do they just have to suck it up? It's when in what age range are you recommended this particular treatment, and in what age range is it recommended that you, do physical therapy. They basically decide the quantities that are appropriate according to cost effectiveness. So in the UK, out-of-pocket rates are low. Quantity determination, like what is actually covered, is really the big focus of containing costs. It's not about keeping these rates under a certain amount. It's really a little bit more about keeping quantities under a certain amount. Now, of course, there are going to be internal rates. So like the government has an amount that they pay for a 1 hour consultation with the doctors. There are ways of paying hospitals that can either be just give this hospital a chunk of money and they're required to treat patients. With hospitals, it's not so much item by item pricing within the government system. But the big key with socialized medicine is this is all in-house with the government. All right, so I would like to say a few things about the patient's perspective. So let me erase this and we'll do that. Actually, let me say a few things comparing this to the US first. So one of the things we don't have in the US is a global budget of any kind. And of course, Medicare is going to negotiate reimbursement rates for Medicare patients, which is everyone over 65 and everyone on disability, which is a lot of healthcare. Like that's a much higher percentage of healthcare than people in that group. Because they're the sicker part of the population. So a lot of what's going on with Medicare, negotiating Medicare rates, is actually somewhat analogous to what's going on in other countries. But of course, there's no global budget. That's something that isn't accounted for. It's actually not legal for them to consider cost effectiveness, like NICE, the cost effectiveness organization in the UK, and the US has a bunch of healthcare systems within healthcare systems. So if you're elderly, you have one system. If you work for a large employer, you're on another system. Small employer, another one. Self-employed, another one. If you are with the US military, you're with another one. So it's a mixture of a bunch of different systems. This video is probably long enough, so I won't go into that, but I just wanted to say this is one of the key differences in terms of costs. But let me talk about patients and their perspective. So if we come up with what matters to patients, here are a few things that come to mind. The out-of-pocket cost of care, like this document, matters a lot to patients. Wait times matter a lot to patients. And I will say wait times are actually wait times exist in every single healthcare system. In the US, for example, the most prestigious doctors, if you want an appointment with them, you might have to wait several months because it's just one person and they cannot handle all of the demand for the best or highest reputation doctor in the field. So wait times depend on a number of factors, and one of those is the quantity of doctors, like the supply of doctors in the country. Is the country churning out lots of doctors, or are there limited seats in medical schools? Wait times are also influenced by patient demand. So of course, if you have zero cost of care, that's going to drive up demand. Patients also care a lot about getting what they need, according to what the doctor says they need. Do you get what you need? And I've put need in quotations because if you have a system like NICE that limits quantities or puts restrictions on what kinds of care doctors can give out to patients, one thing the doctor could do is just not mention that this is a treatment available. Say, this is all we can do in the given system, or maybe even just say this is recommended care. Because of course NICE, the cost effectiveness organization in the UK, recommends things based on appropriateness of care and cost. Both of those are under consideration. Whereas in the US or in other countries, the doctor may tell you about all available treatments, and therefore you may actually have a different perception of what kind of care is needed depending on how your doctor communicates with you. And that could matter a lot in terms of your experience of care. And now that I'm talking about this, I'm realizing that this list could go on, and I'm sure this video is long enough. So I think I will stop, but I hope this has given you a framework for starting to think about different healthcare systems. When you're thinking about the systems, I think it's really helpful to think about the different players and the relationships that they have, even more so than the specifics of these documents. Because the specifics of these documents actually change over time. They're renegotiated every year, and information that's, say, 5 years old in terms of what's on these documents can change. So what is a healthcare system? Well, that's a complicated question, but I think the best way of thinking about it is the relationships between the different players rather than the current specifications of the rules.